Sir, please begin.
Okay. Good afternoon, one and all present over here on this online platform of PU webinar. Today we are going to have the session on physiotherapy in leprosy. Yes, our speaker for today is the Dr. Priyanka. She is having the experience of 15 years in the clinical and the academic. Currently, she is working in the national program under the government of India. She has done many workshops, and I request my speaker now to tell something about the PT in that is called the physiotherapy in leprosy. So over to you, ma'am.
Thank you so much, Dr. Nilesh, for such a kind introduction. And I am, for all, I would like to firstly welcome you all and good afternoon, everyone. I am Dr. Priyanka Edwin Herald, and I am from district of Ratlam, that is in the state of Madhya Pradesh. And I am working as a physiotherapist in National Leprosy Eradication Program from past 7.5 to 8 years. So today I'll be sharing my knowledge about the leprosy disease and how as physiotherapists we can make a larger difference in the treatment of the leprosy patients. So today I will be giving my webinar on physiotherapy in leprosy. So today my topic is physiotherapy in leprosy. As you know, as physiotherapists, we all don't know much about this disease, and as it is not included uh, effectively and largely in our course. So I would like to give a brief idea about what exactly is leprosy and how we can help the leprosy patient being a physiotherapist in this field. So the first and most important point about leprosy is its facts, basic facts. What about the leprosy? So leprosy, as you know all, that leprosy is also known as Hansen's disease. It is a chronic infectious disease which is caused by Mycobacterium leprae. So leprosy is taken, actually leprosy word is taken by lepra. It's a Greek word which means scaly. And Hansen is the name of a physician, that is Gerhard Armour Hansen, who first identified this Mycobacterium leprae. So basically, leprosy is caused by a bacteria, very small Mycobacterium leprae bacteria, and it affects the major part of the body, and mainly it affects three main parts of the body, that is the skin, mainly the peripheral nerves, and occasionally the respiratory tract, mucosa of respiratory tract. And we all know that if it is not treated on time, the leprosy can cause permanent and progressive physical disability. So here we have a major role as a physiotherapist to decrease its progressive physical deformities in the leprosy patients. Now, next slide is about, again, the basic fact about leprosy. So we should know how this disease spread and what is actually its incubation period. So how does leprosy spread? Man is the only source of Mycobacterium leprae. It means it is transmitted from human being to human being only. It is transmitted through droplet infection through respiratory tract or skin erosion, and the major site of infection are nose and mouth. That is why the leprosy bacteria germinate and develop inside the respiratory tract, mainly the nasal area, and then it spread inside the body. And very important point about leprosy is its incubation period. The incubation period is very long in leprosy. It is as small as 6 months or as long as 10 to 30 years. This makes this disease very difficult to treat because of its long incubation period, and that is why it is still prevalent in our country. It is very difficult to eradicate this disease because of its long incubation period. But if we take an average, so average incubation period can be of 2 to 5 years. Now, what are the main clinical features? What are the main signs and symptoms we find in the disease? There are so many symptoms in the leprosy disease, but I have jotted down the three major points which has main clinical features of the disease. So first we have skin patch. So there will be a skin lesion or skin patch anywhere in the body. That skin patch can be of darker color or of a lighter color of the skin of the patient. So it should be different than the skin color. And very important part, if you see a patch on the patient's skin, there then we check the patch sensation by the point of a simple ball pen. If we touch on the skin of the area of the patch, and if the patient doesn't feel that touch, then we say that sensation is lost in that area. So skin patch with definite loss of sensation. And third, the patch is also devoid of hair and sweating. So these are the three main features of the skin patch. Then secondary, as leprosy involves peripheral nerves, so there has to have a sensory loss. So sensory loss is present over the hand or foot, and there can also be a corneal sensation loss because of the nerve affected which supplies the cornea. And thirdly, and most importantly, there will be a motor loss because peripheral nerves are involved. Then the peripheral nerves, whichever that peripheral nerves supply whichever muscle, that muscles get weakened, and later on they get paralyzed. So we have motor paralysis in hands, feet, and eyes, which causes impairment. So these are the main clinical features of leprosy. Now we come how we diagnose the leprosy, how we make confirmation of the disease in any patient. So there are three cardinal signs of leprosy. First and most important cardinal sign is a hypopigmented or reddish or darker lesion with definite loss of sensation. As you can see in the picture, there is a patch at the back of the patient, and that is hypopigmented. So there has to have a patch anywhere in the body, and that patch should have a loss of sensation. So that is the first main cardinal sign. Second, there is involvement of the peripheral nerve. Any peripheral nerve is involved. So what all signs we see in that peripheral nerve involvement, the nerve has to get thickened, or its consistency is changed, and there will be loss of sensation to the area supplied by the nerve, and there will be weakness of the muscles of hands, feet, or face, because where the nerve is supplied. So this gives our the second cardinal sign, that is involvement of the peripheral nerve. And third and most important cardinal sign of leprosy is presence of Mycobacterium leprae in the slit skin smear. And now you want to know what is a slit skin smear. It is a laboratory test in which we just scrap a small portion of skin from the area of the patch, where the patch is present in the patient. We take a small scrap of skin, and then we get it tested inside the microscope, and there we can, it is, as Mycobacterium bacilli is an acid fast bacilli, so it gets inked, and then we can see its presence inside the laboratory, inside the microscope. So if there is a presence of Mycobacterium leprae in the slit skin smear, then it is totally confirmed that patient has this disease. So these are the three cardinal signs: hypopigmented patch, involvement of the peripheral nerve, and third is the presence of Mycobacterium leprae in the smear. Now we come to the classification of leprosy. Leprosy, as you can see, has got varied number of symptoms. So WHO, World Health Organization, has classified this disease into two major classification. First is the PB, that is called paucibacillary, and second one is the MB, that is multibacillary. Paucibacillary, by the name itself, you can understand the number of bacilli are less, and in multibacillary, the number of bacilli are more in the body. So according to the cardinal signs, we can differentiate between PB and MB. As you can see, the first are the skin lesion. If there is 1 to 5 patches or 1 to 5 skin lesions present all over the body in any patient, that patient counts under PB category. And if there is 6 patches or 6 and above, then we can say that patient is under multibacillary category. Secondly, about the peripheral nerve. If there is only one nerve is involved, then it is PB case. And if there is more than one nerve involvement, two or any amount of nerve are involved, then that patient comes under the multibacillary category. And thirdly and importantly, about the skin smear. In PB case, the skin smear is always negative. It doesn't come positive, but it if at all it comes positive at any site, then that patient is counted under MB, that is multibacillary category. So there are mainly two classification of leprosy, PB and MB, and according to this classification, the treatment has been divided between the PB patients and the MB patients. Now, very importantly, we have to know what all nerves are affected in leprosy. First and foremost point, and very important point, is only the superficial nerves are affected. Only the peripheral or superficial nerves are affected. Why? Because the Mycobacterium leprae has an affinity towards the cooler part of the body. So never ever it affects the deep seated nerves inside the body. It always affects the superficial nerves which comes over the bone or very near to the skin. Then only it gets affected. And nerves in the upper limbs are more often affected than the lower limb. And these are the main nerves you can see in the figure itself. These are the main nerves which are affected in the leprosy patients. First is the ulnar nerve, median nerve, great auricular. Great auricular is just behind the ear, it comes at the neck. And then superficial radial, common peroneal, which is also called as lateral popliteal, posterior tibial, facial, and trigeminal. So these are the nerves which are affected in the leprosy, and these all nerves are superficial nerves. Now we come to the nerve examination. How we examine the nerve. Nerve examination is another very important work and important factor of a physiotherapist, because as I am working in this field, I only do the nerve examination of all the patients. So nerve examination involves two main processes. First is the nerve palpation, and second is the nerve function assessment. Nerve palpation, we palpate the nerve. For nerve palpation, we use the tip of these three fingers and we palpate very gently over the course of the nerve where the nerve is very superficial. So during palpation, we see these 3 points: thickening of the nerve, whether the nerve has thickened or not, whether the nerve is tender. If we touch on the nerve when we palpate, the patient feels sudden pain and sudden increase of the sensation. And third, we palpate the consistency, whether the nerve has softened or it has got hardened or not. These 3 points we see in the nerve palpation. And secondly, we see the nerve function assessment. As you can see, the nerve functions are of two types: sensory and motor. So these we can check in the nerve examination. So these 2 points, nerve palpation and nerve function assessment, we will be seeing further for all the nerves. So first and foremost, we will see the trigeminal and facial nerve, the two main nerves which are affected in the face of the leprosy patient. First nerve is the trigeminal nerve. The mainly ophthalmic branch of the trigeminal nerve is affected in the leprosy, and that branch supplies the sensation over the cornea. And we check the trigeminal nerve by checking the blinking of the patient. If the patient is blinking, the blinking is present or not. If the blinking is absent in any patient, then we can say that trigeminal nerve is affected. For that, you can see in the picture, just small portion of cotton is used and we stroke it on the lateral side of the eye. And if during stroke the patient blinks the eye, then we can say, okay, yes, trigeminal nerve is okay, it is not affected. But if blinking is lost, then trigeminal nerve is affected in the patient. And for facial nerve, In facial nerve, the zygomatic branch is affected in the leprosy. That zygomatic branch supply the muscle that is orbicularis oculi, and you all know orbicularis oculi muscle closes the eye. So we ask the patient to close the eye and we try to forcibly open it. If the patient closes the eye against our resistance, then we can say ki facial nerve is okay, it is not affected. And if the patient doesn't able to close his eye properly, then we say that facial nerve is affected and it has got the condition leprosy in it. Then next examination, a very important nerve is ulnar nerve examination. Ulnar nerve is majorly and most commonly infected in any of leprosy patient. For it, we palpate the nerve. The ulnar nerve comes superficial at the back of the medial epicondyle in the ulnar groove, medial epicondyle of the humerus at the ulnar groove. There we palpate the nerve, and when we palpate, we see all the 3 points, that is thickening, its tenderness, or it is tender or not, and its consistency. And then we see its motor assessment. Motor paralysis is present and or not. And you all know that ulnar nerve supplies the intrinsic muscles of the hand. So for that, we ask the patient to abduct the little finger out. For that, we use abductor digiti minimi for abduction. So we are checking this muscle, abductor digiti minimi. We ask the patient to abduct the little finger out, and if he is able to do so, then we apply a little resistance over it, and then we again ask him to abduct the finger again against our resistance. If the patient is able to do both the things, then we say okay, there is no motor paralysis or there is no muscle weakness present. So this is how we test the motor paralysis or the weakness of the muscle. And for sensory loss, you can see in the picture, the ulnar nerve supplies the lateral 1.5 fingers, that is little, and half of the ring finger and the area below the palm and back of the hand also. So this area we check for the sensation. Again, for checking the sensation, we take a simple ball pen, and from its tip we check by putting simply over the area supplied by the ulnar nerve. And if in this area patient say I cannot feel the tip of the ball pen, then we can say okay, the sensation is lost in this area and ulnar nerve is affected. Now, next nerve is the median nerve, which is very commonly again affected in leprosy patient. For median nerve palpation, median nerve comes superficial at the carpal tunnel, and it is just beneath the flexor retinaculum at the wrist, and it is lateral to the palmaris longus tendon. Everyone can palpate and can see their palmaris longus tendon, and just lateral to the palmaris longus tendon we palpate the nerve. And if the patient feel any tenderness or if there is any thickening, then we say that median nerve is affected. Now we come to the motor examination of the median nerve. For motor examination, median nerve, you all know, supplies the thenar eminence muscle, and mainly we test about the abductor pollicis and opponens pollicis, abductor pollicis brevis and opponens pollicis. For that, we ask the patient to abduct the thumb upward, and if he is able to do so, then we apply resistance as at the base of the metacarpal, downward resistance we are applying, and we ask the patient to resist the pressure which we are applying. If he is able to do so, then we say okay, there is no muscle weakness, there is no motor loss due to median nerve. And for the sensation, we check again by the help of the tip of the ball pen, and you know, as you can see in the picture also, median nerve supplies the median 3.5 fingers, and there we can check about the sensation of the median nerve. Next is the radial nerve. Radial nerve comes superficial at the radial groove. Where is the radial groove? Radial groove is present at the shaft of the humerus, just behind the deltoid tuberosity, and there you can palpate the radial nerve. Radial nerve is little difficult to palpate because the muscle bulk is more over the upper arm. So radial nerve is quite difficult to palpate, but still, if it gets thickened, or if it gets tender, then we can palpate very easily in this area. Now, how we check the motor involvement of the radial nerve? You know, the radial nerve supplies the extensors of the wrist. So simply we ask the patient to extend his wrist, and if he's able to extend, then we apply a little pressure over it, and then we ask again the patient to extend the wrist against our resistance. If he's able to do so, then we say, okay, there is no motor loss. And for radial nerve, sensory examination, you can see in the picture, the radial nerve supplies the three and thumb, the index and middle finger at the back of the dorsum of the hand. So this is the area supplied by the radial nerve. So we check again by the point of a ball pen on this area for the sensory involvement of radial nerve. Next is the lateral popliteal nerve. Lateral popliteal nerve, or common peroneal nerve, it comes superficial. As you can see in the picture, it comes superficial at the apex, behind just apex of the fibula. And so just behind the knee, at the apex of the fibula, we palpate the lateral popliteal nerve. Again, we palpate it for thickening, tenderness, and consistency. And if any of these three is present, then we can say lateral popliteal nerve is involved. And lateral popliteal nerve supplies the dorsiflexus of the foot. So we ask the patient to dorsiflex his foot, and if he is able to do so, we apply the resistance, and if he can do against the resistance also, then we say lateral popliteal nerve is not affected. And for sensory nerve examination, in the picture you can see the blue area. This is all the mainly the dorsum of the foot is the area supplied, sensory supply of the lateral popliteal nerve. So we can check the sensation again there with the help of the tip of a simple ball pen. Next important nerve, and very commonly affected in leprosy, that is posterior nerve. So posterior tibial nerve, actually posterior tibial nerve comes superficial just behind the medial malleolus, at the ankle behind the medial malleolus. You can see in the picture the therapist is palpating, and there, if the patient feels tenderness, thickening, or any change in the consistency, then we can say the tibial nerve, posterior tibial nerve is affected. And posterior tibial nerve supplies the intrinsic muscle of the foot. So we ask the patient to fan his toes. If he is able to fan his toes out, then we can apply resistance on both the sides. And if he is able to do the fanning against the resistance, then there is no motor loss present. But very importantly, the posterior tibial nerve supplies the area of the sole of the foot. And you can see in the picture, majorly over the sole, the posterior tibial nerve is supplied. So if it is affected, the sensation at the sole of the foot gets affected, and which is very common debilitating problem in leprosy, because if the patient doesn't have any sensation in the sole, there can be injury, erosion, cracks, ulcers present, which I will discuss earlier. So it is very important nerve in the leprosy. So this is all about the nerve examination. Now, what is the treatment of leprosy, medical treatment of leprosy? So like you must be knowing about TB disease. In TB, DOTS treatment is there, as same as TB. There is MDT treatment, multi-drug therapy treatment in the leprosy. This MDT treatment was introduced in 1982, and it involves three major drugs, that is rifampicin, clofazimine, and dapsone. Rifampicin, clofazimine, and dapsone. And these three drugs are given in regular intervals and in other doses to the patient, as compared to the PB patient and MB patient, paucibacillary and multibacillary patient. You can see in the picture the green card, or the green blister pack, is of PB adult treatment, and the red or pink card is of the MB adult blister pack. So in this package, there are medicine available for whole of the month for 28 days, and for PB patient we give 6 blister packs in whole of the year, and there is for MB patient there are 12 blister packs we give for whole of the year. So PB patient is just 6 months of treatment, and MB patient it is 12 months of treatment of the same drugs. Now we come to disabilities seen in leprosy. Leprosy involves two types of major disability, primary and secondary. What are the primary disability? As we now know that leprosy involves the skin and the peripheral nerve. So anything which is caused by the damage of the nerve comes under primary. So primary occur as a result of nerve damage. Example, loss of sensation. And if because of loss of sensation some other disability has occurred in leprosy, that disability is called secondary disability. So secondary disability occurs due to neglected primary disability, and secondary disability like plantar or foot ulcers and contractures. In this slide you can see how it develops, the how primary disability develops into secondary. So above you can see process of deformity in hands and feet. If any nerve is damaged, nerves involve three types of work: autonomous, sensory and motor. So if any nerve is involved, there will be loss of sweat, loss of sensation and loss of motor. Loss of sweat causes cracks and then it causes ulcer. Loss of sensation causes injury, any pressure source, and then also it causes ulcer. And motor function is lost, then it causes weakness of the muscle, and then it causes contracture or deformity. So ulcer and contracture are the secondary disability because of the primary disability which is caused in the nerve. And secondly, in down you can see the process of deformity in eyes. So if any nerve like trigeminal or facial nerve is affected in the nerve, then because of that, if facial nerve is affected, then the patient will not be able to close his eyes properly. So that is called as legophthalmos, which can cause exposure keratitis or corneal ulcer, and later on it can develop blindness. And if trigeminal nerve is affected, that can corneal anesthesia, which can cause corneal ulcer later on, and which can also develop blindness. So blindness is the secondary impairment or secondary disability caused by nerve damage of the face. Now we will see in this chart what are the major disabilities in leprosy. I have jotted down only the major nerves which is affected in the leprosy and what all deformities they cause. So first site is the face. Face involves two major nerves, facial nerve and trigeminal. So if facial nerve is affected, the patient doesn't able to close his eyes properly. So that is inability to close the eye, which is called legophthalmos. And if trigeminal nerve is affected, then there will be loss of sensation over cornea. In hand, if the ulnar nerve is affected, there will be clawing of fourth and fifth finger. Fourth and fifth finger will be clawed, and there will be loss of sensation over little and inner half of the ring finger. If median nerve alone is affected, then patient will not be able to abduct the thumb and touch the opposite fingers. And that deformity you all know is called ape thumb deformity. The thumb is like this only. Patient will not be able to abduct and oppose the thumb. And there will be loss of sensation over thumb, index and middle finger and outer half of the ring finger. And commonly both the nerves are affected, ulnar and median. If both the nerves are affected, then we get complete claw hand and loss of sensation over whole of the palm. If the radial nerve is affected, if the radial nerve, as you can see, the radial nerve supplies the extensors of the wrist. If the radial nerve is affected, there will be no extension, there will be wrist drop, and there will be loss of sensation at the back of the hand. And in the foot, the common peroneal nerve or lateral popliteal nerve is affected, then as you know, it supplies the dorsiflexus of the foot. If it is not dorsiflexion, then the foot drop will be there, and there will be loss of sensation over lower leg and dorsum of foot. And last, the nerve, posterior tibial nerve. If posterior tibial nerve is affected, there will be clawing of toes and there will be loss of sensation over the sole of the foot. So these are very important and very major disabilities which is caused in leprosy because of the involvement of the nerves. One by one, I will show you the figures and the pictures. Facial nerve deformity. See, the patient is not able to close his eyes properly. There is a gap, and this deformity or disability is called legophthalmos. See, ulnar nerve deformity. If only ulnar nerve is affected, there will be ulnar claw hand, and both median and ulnar nerve is affected, there will be complete claw hand. Now, next is the median nerve and radial nerve deformity. If only median nerve is affected, there will be ape thumb deformity, and if the radial nerve is affected, there will be wrist drop. Now, if the popliteal nerve is affected, lateral popliteal, there will be foot drop in the patient. And if there will be posterior tibial nerve is affected, there will be claw toes. Claw toes looks like this. So these are the major disability or deformity present in leprosy because of the involvement of peripheral nerve. Now, due to the presence of this deformity, WHO has graded the leprosy cases into some grades. So, there are 3 grades for hands and feet, and there are 2 grades for eye. So, for hand and feet, there are 3 grades: 0, 1, and 2. For 0 grade, if the patient is present only patches, there is no loss of sensation, and there is no visible deformity in the patient, that patient comes under grade 0. And if there is loss of sensation but there is no visible deformity of damage, only there is loss of sensation, then that patient comes under grade 1. But if the patient has any of the previous deformity which we have seen or any damage present, then that patient comes under grade 2, which is a very bad condition of the patient. And for eye, are only 2 grading, 0 and 2. If there are no eye problem like vision is normal, there is no lid gap, blinking is normal, then that patient comes under grade 0. But if the patient doesn't able to count the fingers at the 6 meters distance of, or if there is a gap in the closure, or if the blinking is absent, then we say that that patient has come under grade 2. So there are these main 3 grades of hand and feet and 2 grades for eye. This is the WHO grading for leprosy patient. Now, these are the aims of physiotherapy. As physiotherapists, what main aims we have and what all treatment procedures we give for the treatment of leprosy. First and foremost aim is to educate the patient in the importance of technique of self-care. Self-care is very important. I'll be sharing few more slides about it. And for with the help of exercises, we try to prevent contracture and to decrease existing contractures or deformity, to overcome the disability, to strengthen the weak muscle, to reduce edema and pain, and to improve blood circulation. So all these aims we can achieve by specific exercises. And next, to identify the eligible patient for reconstructive surgery. So if there is presence of any deformity like claw hand or foot drop or legophthalmos, these patients are given or are referred for further surgeries. Those surgeries are called reconstructive surgery. So we as physiotherapists select those patients which can be benefited from the reconstructive surgery. And if there is reconstructive surgery in a patient, so we give pre-op and post-op physiotherapy and restoration of function. So these are the main aims of physiotherapy in leprosy. So first and foremost, about the self-care. See, these slides are slightly disturbing because this is what happens in a leprosy patient if he or she doesn't take good care of their sole, foot or hand. So we have to educate the patient in the importance and technique of self-care. If there is loss of sensation and sweat present in the hands and sole of the foot, so we have in hands we have blisters, in feet we have dryness and cracks, that can ultimately cause ulcers, and these ulcer takes very very long time to heal. So self care is very important. For self care, we give hope therapy. Hope therapy stands for hydrooleo physical exercise therapy, which means it involves water, it involves oil, and it involves exercise for the treatment. So we ask the patient to inspect their hands and feet daily for the presence of any blisters, any red spots, warm spots, tender spots in the hand or the feet. And we ask the patient to soak their hand and feet daily in water for 20 to 30 minutes. Like you can see in the figure, the patients are soaking inside a tub for 20 to 30 minutes, and we can add a little bit of salt or any antiseptic solution in the water. So after soaking, the patient is asked to take out their feet and hand and do the scraping. Scraping means to rub off the hard or surface or the hard skin. So scraping of hard skin is done using a pumice stone or any simple brush. And after scraping on the wet hand and wet feet only, we apply oil. So oiling after soaking, apply oil or Vaseline without drying the part. This is very important. The part has to have been a wet only. There should not be any drying, and on the wet part only we apply oil or Vaseline, so it locks the moisture inside and it prevents dryness, which can further prevents the presence of any cracks or ulcer in the hand and feet of the patient. So that is the about self care. Now we come to the major exercises involved. Actually, major exercises according to the nerve involved. So first, I am telling about the ulnar nerve. If the ulnar nerve is affected, I have shared earlier also, the ulnar nerve supplies the intrinsic muscles of the hand. Then fifth lumbricus, flexor digitorum profundus, fourth and fifth flexor carpi ulnaris. All these muscles get affected if ulnar nerve is involved. So we give active exercise. If the patient is able to do, we give active exercise. If he is not able to do actively, then we assist. And if it not at all able to do, if there is presence of any contractures or claw hand is present, then we give them passive exercise. So simply, if the patient is fine, he is able to do the exercise, we ask the patient to adduct and abduct his fingers on flats. We ask the patient to place the palm on a flat surface, and we ask the patient to abduct and adduct the finger as often as possible. For active assisted, the MCP joints are flexed or supported in 90 degrees by other hand, and only the IP joints are flexed and extended. This is called the active assisted exercise for ulnar nerve. And for passive exercise, hand is placed on a flat surface with palm facing upward. Palm or thinner area of the unaffected hand is used gently to straighten the fingers out. You can see these exercises in this slide. First slide shows the active exercise, and second the passive exercise for ulnar nerve muscles. Now next is the median nerve. Median nerve, supplies the thinner eminence muscles, and we have to give the active exercises for this. So just simply we ask the patient to abduct the thumb and do the opponent's position of the thumb for all the fingers. These are the active exercise for the median nerve. If the patient is not able to do so, then we assist the thumb to oppose all the fingers, and we assist the thumb to abduct. And if at all he is not able to do, then we do passively extend the thumb, passively abduct the thumb, like you can see in these pictures. Active exercise and passively. If the patient is not able to do, then we have to do passively for him. Next, for the radial nerve, very simple, wrist extension. So if the patient is able to extend the wrist, then the patient is asked to extend the wrist as often as possible and repeat these exercises every 2 to 3 hours. And if is not able to do so, then we can take the unaffected hand and we extend and stretch the affected hand, or we can do this exercise on the table also for stretching the wrist and extending the wrist. As you can see the picture, first picture shows the active extension, second is the passive extension or passive stretching, and by the help of the table the patient is also can do wrist extension stretch for radial nerve. So you can see this is the slide of some of my patients. These are the patients. These are slides of two my patients, and these both the patients have complete claw hand for both the hands, before and after pictures, and you can see before. The exercises his hand was completely clawed, and after the exercise the hand has gone very well and it is almost like normal. And second picture also, this patient has got bilateral claw hand, his hand was like this, and now after exercises his condition is much better than before. So this is see how our exercise can help in treating a very important deformities of the hand. So all these there are very these are very simple exercises, but if you do the exercises consistently on the patient, then it will definitely give you the desired results. Now we come to the lower limb nerves, lateral popliteal and posterior tibial. Lateral popliteal nerve supplies the dorsiflexus of the foot. So we ask the patient to sit high with leg not supported by ground and foot is dorsiflect, and this position is maintained for about 15 to 20 seconds. And if patient is not able to do that, then we ask the patient to try to dorsiflex, and we assist in dorsiflexion with the help of a towel or theraband or another hand also. And for posterior tibial nerve, patient is positioned with affected leg resting on the other thigh, and patient can use their hands to stretch the toes. You can see both the exercises in this picture. First picture is for exercises of lateral popliteal nerve, and second is exercise for posterior tibial nerve. So these are the major exercises for the upper limb and lower limb muscle. Now, what about the facial? Facial nerve, mainly I have told you zygomatic branch of facial nerve is affected, which is the orbicularis oculi muscle. So in this, the patient is asked to close the eye, tightly close the eye and hold it for 10 to 20 counts and then open it and repeat this exercise 5 to 10 times hourly. But if the patient is not able to do so, then patient should place his index finger on the lateral side of the eye and gently pull the eyelid laterally so that it closes. This is how we give passive exercise for orbicularis oculi muscle. So these are the main exercise which we give for leprosy patient. Now next slide is very important slide because this is the type of sandals or footwear we give for leprosy patient who have sensory loss over their sole. Means if posterior tibial nerve is affected and there is a loss of sensation, then this kind of footwear is given, and this footwear is called microcellular rubber footwear, which is in short we called it MCR footwear. In this MCR footwear, the insole, the inner sole is soft, but the outer sole, as you can see in the figure, is hard. This hard outer sole prevents any injury, outer injury into the foot of the hand, and there is a presence of back strap. Back strap is actually present to avoid slipping of the foot from the sandals. And very importantly, there are no metal, there are no buckles in these sandals, only the velcro is used, because if we use any kind of metal and there is a sensory loss in the foot, then that metal can cause further injury or damage to the foot. And these MCR footwear are designed according to the size of the foot, They are never repaired with any kind of nails or metal, and we supply two pairs of MCR footwear in an year to a patient, and according to their deformity, various modifications are done in the MCR. So this is a very important part of the treatment of leprosy patient, that is MCR footwear. Now, if there are deformities present in leprosy and those deformities are not being treated by exercise, so we refer those patients for surgery. So those surgeries in the leprosy are called reconstructive surgeries. So mainly these surgeries are all tendon transfers. So you can see I have jotted down the name of the main surgeries, like in legophthalmos, when the patient is not able to close his eye properly, one static procedure is called tarsorrhaphy, where the eyelids are sutured, and one is the dynamic procedure where temporalis muscle is transferred for the closure of for the closure of eye for the function of orbicularis oculi muscle. Or if there is so much of opening of eye, there's no muscle like temporalis muscle if also not getting transferred, then complete lid closure is given to the patient. Now for claw hand and ape thumb deformity. Claw hand and ape thumb, very common and very popular surgery is done, that is lasso technique, where the flexor digitorum sublimis tendons are transferred and is pulleyed for the claw hand deformities. Secondly, extensor carpi radialis longus, palmaris longus, flexor digitorum superficialis tendon transfers are done, or opponent's replacements are done. And for foot drop, that is tibialis posterior transfer, because dorsiflexors are not working, so tibialis posterior is transferred for their action, and also transfer of peroneus longus tendon for toe extensors are done, and lengthening of tendoachilles is done. So these are the major surgeries, reconstructive surgery we see in leprosy patients. So if there is a reconstructive surgery done in a patient, so we as a physiotherapist work pre-operatively and post-operatively as well. So what is pre-op physiotherapy? Pre-op physiotherapy is actually these are the points for the main aims or points we do in pre-op physio, that is active assisted or active movements we give to maintain joint flexibility. For isolation exercises for tendon transfer, the on which tendon is getting transferred, so we give strengthening exercises, isolation exercises to that particular muscle. So isometric exercises we give for tendon transfers to increase their strength. And if the patient has pain or stiffness, then we give wax therapy, TENS and ultrasound, and mild mobilization to prevent further stiffness of the joint. So these are the pre-op physiotherapy. Now post-op. After post-op means if there is a reconstructive surgery, for we see for first for the claw hand. So first for claw hand, there is a slab is applied, or plaster slab is applied, and that hand is uh, put under the plaster or immobilized for 3 weeks in this position. This position is called lumbrical position, where the MCP joint is flexed, PIP and DIP are extended, and the thumb is in abduction position. So this is the immobilization position of the hand for 3 weeks. So after removal of the plaster, we give isolation and re-education of transferred muscle. We maintain this lumbrical position through splinting, because the plaster has been removed, so we give splints to maintain this lumbrical position, and we give simple strengthening graded exercises and coordination exercises for you different grasp position and to maintain this position. Because if we suddenly extend the MCP joint, all the reconstructive surgery will fail. So we do it gently accordingly through first, second, third, and fourth week after the removal of plaster. And similarly, we do for foot drop muscle. For foot drop muscle, immobilization is done for 3 weeks, and training is done for transverse muscle for new action of dorsiflexion. And we apply pop back slab in dorsiflexion pop back slab is applied, and patient is not advised to bear weight on that particular foot. So on 41st post-op day, partial weight bearing starts, and full weight bearing and walking is done on the 42nd day. So this is all about the claw hand and foot drop post-op physiotherapy. And for leg ophthalmos, as you have seen, I have discussed it earlier, temporalis muscle is transferred for orbicularis oculi muscle action. So there is a specific diet after the surgery, as in first week only liquid diet is given, for second week there is semi solid diet is given, third week normal diet is given, means the patient starts biting, and for fourth week strong exercises and biting on hard substances and hold contraction for biting is given for a longer period of time. So this is how we give post-op physiotherapy for reconstructive surgery for leg ophthalmos. Now, lastly, there is very important another point in leprosy patient, that is leprosy reaction. Leprosy react in any leprosy patient, whether he is getting treatment or not, this reaction occurs, and these reactions are called leprosy reaction. What is a leprosy reaction? It is an acute inflammatory response during the course of disease. Why it develops? Because it is an immunity response of our body towards the mycobacterium leprae. So it develops more likely on the patient which have many lesions, or lesion which are closer to nerve, lesion on face or during pregnancy. Those patients are get more affected for leprosy reaction. Leprosy reaction is dangerous to the patient, so it should promptly be treated to prevent disability, and these patients should be monitored more frequently. And for your kind information, there are mainly two types of lepra reaction: type 1 and type 2. Type 1 is called reversal reaction, and type 2 is called erythema nodosum leprosum. In this slide, you can see both the reactions in the figure and the picture also. In type 1, the existing patches or existing lesion of the leprosy patient becomes swollen, warm, and tender, and nerves actually become very enlarged, very painful and tender, and no other organs are affected. So this is type 1. And type 2, as the name suggests, erythema leprosum nodosum, then that in type 2 reaction there is a presence of nodules all over the body. You can see in the picture also, there is a presence of red, painful, tender subcutaneous nodules. And nerves in type 2 is not as commonly as affected as type 1, but other organs or other part of the body like eyes, joints, bone, testes, and kidneys are affected in type 2, and there is presence of fever, joint pain, and fatigue. So if any of these symptoms are present in the leprosy patient, then those patient comes under lepra reaction or leprosy reaction, and we treat them accordingly. So according to the medicine or medical management of lepra reaction, we give them steroids or symptomatic treatment. As if he's got any fever, we give the antipyretics, or if he has got pain, then we give the painkiller drugs. So this is how we medically manage the lepra reaction. But in case of physiotherapy, very importantly, we give rest to the affected limb in the acute phase by splinting. Especially we give night splint, and once the pain of the acute phase has reduced, then we give passive stretching for any weakened muscle. We give joint mobility, active exercises to strengthen the weakened muscle, but this we give after the completion of the acute phase. And thirdly, and very importantly, soaking and oiling, as we have discussed earlier, for dry skin helps to prevent cracking and preserves the integrity of the epidermis in the lepra reaction. This is our main points of physiotherapy management in lepra reactions. So this is simple. Some of the splints of hand. First is the abductor splint. Second are the lumbrical splint of the fingers, and third is the gutter splint of the fingers, which we give in the leprosy patient to decrease their deformity and to increase the normal functioning of the hand. And these are the modification of appliances if the leprosy patient has lost their digits, or if they have major debilitating fixed deformities which we cannot do anything with exercise or reconstructive surgeries. Then we give these appliances to the patient to increase their ability and to make their life easier. You can see we can give spoons holders, cup holders. We make the tip of the pen broader for them to write. So these are all the appliances which we give for leprosy patients. So this is all about leprosy. And last but not the least, I would like to share these thoughts with all of you that leprosy is a disease. It is not the curse of God, which is still prevalent in our country. So please treat leprosy as a disease only, because leprosy is completely curable if treated in time, and full course of treatment is available free of cost in all government hospitals and health centers. And disabilities and deformities can be corrected. If at all it happens in a leprosy patient, then it can be corrected by reconstructive surgery, self and physiotherapy. And please accept leprosy affected person socially in a society and do not discriminate with them. So this is my humble request to all of you. So if you also see any leprosy patient, do not discriminate, and please give them proper treatment and treat them as any other disease. So thank you all for listening, and hope my webinar and my knowledge gives you some idea about leprosy, and help you all in the further treatment if you see any leprosy patient in your treatment procedures. Thank you.
Thank you, ma'am, for explaining this thing. Ma'am, one question is there. Uh, that how we can explain as a physiotherapist to the
Hmm.
society that this is a normal disease, not a curse of God, or as you have said. So
Huh.
how we can balance? Because as you're talking about the patient is also having certain kind of fear to go into the society. So how we can manage that thing, counseling to that
Right.
patient as a
I,
physiotherapist?
right. Thank you. That is a very good question. Actually, leprosy is simple a disease which affects the skin and the nerve. So we counsel the patient as we say it is a skin disease. It is not any disease which is a curse of God. It's as simple as any skin disease. It looks bad, yes, but it can be treated if you come early to us, and it is curable throughout. And we don't have to we don't have to hide it from anyone else, because it doesn't spread that much. Leprosy spread is very less. Like we as leprosy therapists, we work among them, but still we know it doesn't spread that much. So we counsel the patient like you have to live a normal life, normal with your family, nothing to worry or fear about, because it is as simple disease and it can be controlled, and it is curable completely by MDT. So this is how we counsel the patient, and we also as doctors and therapists should not discriminate among them.
Okay,
Yes.
thank you very much, ma'am, on behalf of our Parul Institute of Physiotherapy and the Parul University, ma'am. Thank you for
Okay.
sharing this valuable knowledge. Thank you very much.
Thank you. Thank you so much. Thank you so much.